And we will get started. Delighted to welcome all of you to Department of Medicine Grand Rounds. This is our last Grand Rounds for the year. So we're ending with psychedelics, which I'm not sure what that says about the year. But to introduce our speaker, Dr. Hutson, I am going to introduce Dr. Jessie Kay, who is a research scientist in our Center for Tobacco Research, CITRI. So Jessie, handing it off to you. Thank you.
Thank you, Lynn. It's my pleasure to introduce our presenter today. Paul Hutson is a pharmacist and distinguished professor at the UW-Madison School of Pharmacy. Paul joined the UW Carbone Cancer Center as an associate member in 1988 and now serves as the faculty leader of the Cancer Center's Cancer Pharmacology Laboratory. His practice areas at UW-Madison have been on the adult solid tumor and the palliative care services. And more recently, he is the director of the UW-Madison Transdisciplinary Center for Research in Psychoactive Substances. The mission of the center is to support research and educational activities regarding psychedelic drugs and related psychoactive compounds. Paul holds multiple FDA investigational drug authorizations for Schedule I drugs and was the principal investigator for the phase 1 clinical trial of psilocybin performed here at UW-Madison. I think we're in for a fascinating presentation today and look forward to a Q&A discussion after Dr. Hutson's presentation. So over to you, Paul. Thanks for joining us today.
Thank you. Thank you, Dr. Schnapp and Dr. Kay. It's a pleasure to be here today with you for Grand Rounds. I wanted to go through my conflict of interest, which is basically stating that I'm not going to be talking about anything that is FDA approved today, so please don't expect that. I did want to emphasize that there is a lot of exciting activity going on, a lot of exciting results coming in from early stage and late stage clinical trials, but we also have some problems to deal with as we look forward to the use of psychedelics in clinical practice down the road. So there are multiple psychoactive drugs that are currently in research. Many of these you're familiar with. One would be, for example, the psilocybin coming from magic mushrooms, the psilocybe species, which are found quite widely distributed around the world. 5-methoxy-DMT is actually extracted from an exudate from the skin of the Sonoran Desert toad. And this is where the expression licking the toad comes from, a very sudden and profound psychedelic experience, but also a very short one, which is leading investigators to be looking at that for a rapid turnaround, if you will, of patients in the clinic. We also have DMT, which is the active ingredient, the psychedelic active ingredient in ayahuasca, the infusion made in typically South America, but also in Central America. And the Banisteropsis vines that you see in this pot actually are added so that it blocks the first pass metabolism of DMT, which otherwise would not be active when taken orally. And so one of the things that is one of the components of active research is trying to figure out how we could administer the DMT through other routes, intranasal, subcutaneous, even topical. Then we also have mescaline, which is derived from the peyote cactus. Now, in all cases, there's a concern about overharvesting and wildcrafting and the sustainability of these natural products. But I will say that all of these compounds and those listed as well, LSD, morning glory, salvia divinorum, and ibogaine, have the active ingredients have been synthesized. And actually, there's a lot of work looking at congeners, not only to make it more sustainable, but more patentable, because the natural products are difficult to patent and difficult to commercialize. So magic mushrooms and the psilocybin that was inside of it was discovered, if you will, in the mid-50s by Robert Wasson, a banking executive who visited here with Maria Sabina, a healer in Mexico, and she is showing him the mushrooms. So he brought this experience with the magic mushrooms, this experience with the healer, Maria, to the United States, and actually it was featured in a issue of Life magazine. However, he did not discover psychedelics or the mushrooms. As we can see from these ancient paintings and pottery carvings, the use of these psychoactive plants and fungi, such as the mushrooms that you see here in these pictures and carvings, pottery, were recognized thousands of years ago. And it's not really clear whether or not the psychedelic was used by the healer or by the healee, or the warrior, or the person that was sick. It may have been taken more for the insight that was gained by the healer about what was wrong or what needed to be done for the battle. It's also not really that new that we have these compounds in a synthetic pure form. The 3-methylene dioxymethamphetamine, which fortunately can be abbreviated as MDMA, was synthesized over a century ago. And LSD was synthesized by Hoffman in 1938. Here we see a picture of Albert Hoffman, and was actually commercialized as Delicid by Sandoz, as was psilocybin, which also was synthesized by Hoffman after it was brought back from Mexico. And even mescaline from the peyote cactus was synthesized and commercialized by Merck. And I wanted to point out to you this labeling on the Delicid, the LSD box. Here's a magnified version of that. You can see that this is a physician's sample. So in the late 60s, you could have asked for and received a physician sample of LSD, 25 micrograms, to do with as you thought fit. And again, it's not clear how many of these tablets were ingested by the clinicians as opposed to the patients themselves to get a sense of what was going on. But certainly it was far more accessible before the 1970 Controlled Substances Act. And now we are seeing this renaissance in the early 2000s, 21st century. A lot of research going on with psychedelics, as you might imagine. You've seen it reported repeatedly in the media. These are some interesting plots from the FDA that show the number of INDs, investigational new drug applications, excuse me, received relating to psychedelics such as LSD, psilocybin, DMT, and so on. And you can see that there's a big jump. This is the last data that I have from 2021, and that has increased from what I understand from talking to FDA staff. And then on the right, you see the percentage of INDs received that are related to psychedelics, right? In this plot, it's 16%. FDA staff again tell me that they receive more IND requests to do research on psychedelics than any other class of medicines. This is reflected by the number of active studies reported on clinicaltrials.gov. You could see that it's predominated by cannabis, THC, marijuana-related studies. But psilocybin species, that is an extract of the mushroom instead of the pure drug, account for 126 active studies. And then we see other psychedelics in lower numbers here, but still very active research. And you need to understand that most of this work is not NIH funded, that it's very rare to find that these studies are NIH funded at this point, although that nut is beginning to crack. As you might imagine, there are a lot of scientific publications that follow from this clinical research activity. Again, this is a little bit dated, but the number of publications and journals reporting more specifically on psychedelics is growing. The data to date in the early trials is strong enough that the FDA has granted psilocybin breakthrough drug status for the treatment of depression. And what's really remarkable is that these studies are based on one, in some cases, 2 doses about a month apart of the psilocybin, not daily dosing, but a single dramatic dose of psilocybin. It's also granted LSD breakthrough drug status for the treatment of anxiety, and MDMA for the treatment of PTSD as an adjunct for the treatment of PTSD. And I want to point out that in all cases, really, I'm arguing that these drugs are used in conjunction with trained professionals that understand how to provide appropriate psychotherapy for the disease. I'm not saying that these are drugs that should be taken in and of by themselves without any preparation or any attendance. Let's talk a little bit about psilocybin itself. Psilocybin is actually a prodrug. It's dephosphorylated very quickly as it's ingested orally. And in fact, when we give it orally, we cannot find any psilocybin circulating in the blood, just the psilocin and its downstream metabolites. It's primarily an agonist at the the serotonin 2A receptor, although it does have activity on other serotonin receptors, and the differences between its affinity and sensitivity towards receptors of the serotonin class and actually some other receptor classes compared to DMT and LSD likely explains the differences that we see in the experience, the psychedelic experience from each of these drugs. One of the reasons that we don't use LSD in our research is that it tends to sit more avidly in the receptor pocket and doesn't come out as quickly. And so the experiences are longer, and that's not bad. It is just more difficult to do a study when we have to stick around with the subject for more than 8 hours for the LSD to come out of the receptor pocket. We see with the psilocybin that the concentration peak is at about 2 hours after an oral dose. Of course, if we give it IV push like we're doing in another study, that happens much more rapidly. Half-life is about 2 to 3 hours. And so we can send these people home in about 8 hours. And that's what we do for many of our studies. Send them home with a trusted caregiver that can kind of keep an eye on them. So the onset's fairly quick, even after an oral dose, and the peak effect follows the concentration pretty closely. That's true of the increases in the blood pressure and heart rate that we see. It's not clear if this is pharmacologic and due to the effect on the adrenergic receptors, or whether it's a function of the awe, the excitement, the anxiety that the people are experiencing with their psychedelic effects. And it seems to these blood pressure increases and heart rate increases follow the concentration of the psilocin fairly well. So it's really not clear to us whether or not it's a pharmacologic effect. But what we do see is that as the dose is increased, as we did in our phase 1 study, that there does not seem to be a dose response to this increase in blood pressure and heart rate. So perhaps they are getting used to the experience itself. We do see nausea fairly commonly. This may be due just to the visual effects that they're seeing while they're sitting down or lying down. Occasionally vomiting, but not terribly, not a big problem for us. What we do see fairly commonly is a mild headache, and this responds well to acetaminophen. Typically, it occurs about 12, 16 hours after the dose. And again, does not seem to be a problem. Very rarely do we see hallucinogenic effects that recur. When they do, they typically come back within about 24 hours and dissipate quickly without any sequela. I do want to emphasize something that I had to relearn as I started getting into this work, is that there's no evidence leading to that dosing with the psilocybin or LSD in these constrained, controlled environments for research leads to a compulsive use disorder. There's no evidence in animal studies or human studies that psilocybin or LSD in these clinical trials leads to later compulsive use. How does it work? We really don't know. One can argue that there is a consciousness, a change in the perception of the world by virtue of just a conscious experience through the psychedelic experience. We'd like to be able to explain it, though, in a more pharmacologic sort of fashion. And that's proven somewhat difficult, although we do have some threads. We do know that it is active primarily at the serotonin 2A receptor. And what seems to happen as it acts in the brain is that it decreases the blood flow and activity in the default mode networks, among other places. And these default mode networks, as measured by EEG and functional MRI, seem to indicate that the ability of the brain to communicate is less constrained amongst various components. On the left, you see this circular diagram where these nodes on the perimeter are pretty much talking just to limited other nodes. And this is what we think is sort of a constrained, possibly you could call it an obsessive thought pattern. Under the influence of the psychedelics, whether it be LSD, psilocybin, and some others of the class, we see that these nodes are able to communicate in far more diverse patterns in the cortex, allowing for increased flexibility in thought. Some have called it desynchronization. And what this seems to do is to cause a more disorganized, if you will, a more entropic thought experience, which may lead to the synesthesias, the smelling of sounds, and the hearing of smells and such. A very diverse, novel experience that we would typically consider to be sort of the pattern of hallucinations. But we also see, after the drug is gone, that we have decreased obsessive thought patterns. Decreased obsessive thought patterns is manifested not only by obsessive compulsive disorders, but also in terms of depression, negativity, and the PTSD. We also see some dramatic results, as I'll show you in a bit, about substance use disorders. And on the bottom, we also see some of this this increased entropic, increased disorganization, if you will, of thought, much more communication between the sections of the brains indicated here in the brighter, more vivid red. However, it may not be the conscious experience. It may not be just the increased diversity of communication within the brain. There's also strong evidence that drugs of this class, not just those that cause a psychedelic experience, but many of these serotonin receptor agonists, lead to an increase in the spine density in the cerebral neurons. And on the right, you see this increases by about 10% after a single dose in this mouse model. And it's durable for weeks, if not months at this point. What's also interesting is that it seems to be sex dependent, that the female mice responded more dramatically to the increase in the spine density than the males in the blue on the right. We see increased spine density, we see increased spine thickness, and we also see increased numbers of synapses formed. So we're seeing this described as neuroplasticity here in Alex Kwan's work from Cumbria. We're also seeing this from David Olson's work at UC Davis. Some really remarkable things. And it also is encouraging that these increases in spine density and thickness, number of synapses, does not necessarily seem to be correlated to the hallucinogenic effects as manifested in these murine models. We can't ask the mice if they're having a good trip or not, but we can measure what we think is a hallucinogenic effect by a rapid head twitch that we see in mice. And that's our model for whether or not hallucination is occurring, if you will. But we also see this increase in spine density in those drugs of this class that do not cause that head twitch. Really exciting. So interesting that there's such a sex difference. So much of this renaissance, if you will, of psychedelic work came out of Johns Hopkins University. Roland Griffiths was the leader of that group. He unfortunately died last year. And Bill Richards on the right was a graduate student with Walter Pahnke in the late 60s and 70s, still is with us working at Johns Hopkins, and is sort of our Rosetta Stone to bring forth some of this knowledge from the late 60s to the 21st century. One of the interesting things that they did here was an early study where they gave Ritalin, methylphenidate, or psilocybin to individuals with a strong spiritual practice. And what they found was that after a single dose of the psilocybin, that these individuals had and continue to have to ascribe to this experience one of the top 5 most meaningful occurrences in their life. You know, this would include births, deaths, marriages, and so on. So there was a dramatic influence in their life in terms of the significance that they attributed to this overall experience of the preparation, the therapists that they were sitting with, and the drug itself. What's also fascinating is that this persisted for over a year. There's been a lot of work, as I've mentioned, in terms of the breakthrough drug status for psilocybin, a lot of activity and enthusiasm regarding its antidepressant effects. These are 2 studies from 2 different groups that are bringing psilocybin to the market, they hope. One is the Goodwin paper that represents the Compass Pathways drug, and on the right is the USONA Institute study. These are both phase 2 studies. Their phase 3 studies are underway. And Dr. Chuck Razan is on faculty here at the University of Wisconsin in the Department of Psychiatry and Human Ecology. And you see similar results here. In the case of the Goodwin study, they had a positive control, if you will, of a very low dose, probably subperceptible of the psilocybin at 1 milligram in the gray bar. And the 25 milligram dose that is also the dose used in the Razan study is in the blue. And you can see that there's an immediate next day drop in the MADRS depression score. And that was true for all of the arms, suggesting that there is a placebo effect with all this psychotherapy that they're receiving. But that returns to a somewhat more of a baseline, still some improvement over time. But look at this, there is a strong durability of this 3 months. And in the case of the USONA study, comparing psilocybin against niacin, that there is a 6-week durability of this after one dose of psilocybin. The phase 3 studies will be comparing it to active SSRIs, but one of the concerns that we've got is that patients need to be tapered off of their SSRIs at this point before they are put onto any of these psilocybin trials. We feel that there's an interaction there, typically a blunting of the psychedelic experience. Again, do you need that psychedelic experience? We're not sure, but at this point, we're trying to maximize that psychedelic experience for the dose. So breakthrough drug status, I've already mentioned. Cybin also has some really promising phase 2 data. It's got a novel psilocybin product in which it substituted some of the hydrogens with deuterium, which changes the pharmacokinetics and a little bit of the entourage effects on the receptors. And that their data looks also very good. These phase 3 registrations trials are underway or soon to start in the new year. And based on that timeframe, we're likely to see these companies providing their new drug applications to the FDA in 2026, maybe early 27. So by late 2027, we may have a decision from the FDA about whether or not psilocybin can be used for the treatment of and as an adjunct to the treatment of depression. This will also lead, if it's approved, to off-label prescribing. And there are other phase 1 and 2 clinical trials underway that really are encouraging in many respects. The University of Wisconsin-Madison group under Dr. Randy Brown and Christopher Nicholas, very active in looking at substance use disorders as well as mechanistic studies. We'll talk a little bit about those in a bit. And then Dr. Moreno in Arizona is finding some really encouraging results with obsessive compulsive disorder after 1 or 2 doses of psilocybin. In addition to LSD, psilocybin also seems to have a very dramatic, rapid effect, improving effect on anxiety. Lower doses of psilocybin seem to have activity in decreasing the incidence and severity, duration of cluster and migraine headaches. This is work done by Manuel Schindler at Yale. And then various pain syndrome studies are underway, and also a lot of interest in the palliative care arena, looking at psilocybin or other psychedelics for the treatment of existential distress in the terminally ill. Not that everybody that is dying should get a dose of psilocybin before they die, but there may be individuals for whom this is going to be a very helpful experience. Now, I mentioned the substance use disorders, and here's some work that came out of a pilot study from Johns Hopkins. This is a study in which they took 15 individuals with an average of 6 failed attempts to stop smoking. And they had some cognitive behavioral therapy preparation and some screening, of course. And then their quit date was the first of 3 doses of psilocybin administered a month apart. Some people only chose to do 2. At 10 weeks, by urinary testing, they found that 80% of these individuals were completely abstinent. There were no metabolites of nicotine in their urine at all. And then at 12 months, we still had about a 60% durability. Again, this is after a 2 to 3 dose course of psilocybin in these individuals. Now, you compare that with the efficacy of nicotine lozenges that I pulled from the Schiffman study, where they had only a 26% abstinence rate at week 24. And this is really encouraging, and it has led to an NIH, one of the first NIH studies looking at psilocybin for the treatment of substance use disorders. There are 3 academic centers looking at this, Johns Hopkins, New York University, and Alabama. And to be fair, this work needs to be done because we only had 15 subjects in this pilot study and 900 in the other. So we really do need to do some rigorous testing to see if this holds up. But we also have some really strong evidence from Peter Hendrick's group at Alabama looking at cocaine decreases in the cocaine use after psilocybin dosing. And then the study from Michael Bogenschutz at New York University, where he took individuals with alcohol use disorder and gave them 2 doses of oral psilocybin 1 month apart. One of the things I really want to highlight is this middle bullet about the number of psychosocial sessions that these individuals experienced. It's going to be one of several points that I'm making about how much preparation, how much psychotherapy and contact these individuals have in the course of their dose of psilocybin. The results were really pretty striking. Their control arm was a fairly high dose of Benadryl diphenhydramine. And you can see that, again, there's a fairly strong placebo effect that after 1 month showed a substantial drop in heavy drinking days. And that was sustained pretty well. So that psychotherapy, that behavioral modification is really important, but there was an additive benefit in this study of adding the psilocybin, 2 doses of psilocybin. And again, they are trying to get some additional, they have additional funding and they're continuing this research. There we go. So I alluded to it. Is the psychedelic experience necessary? And one of the things that the Hopkins group did was to compare their rating of spiritual significance that I showed you in that histogram against a mysticism score, and the scale of mysticism that they had, that they used and was still used by many. The mystical experience questionnaire is listed here. And the higher the mysticism score, the greater the significance that these individuals ascribed to their experience. Now, that is interestingly not the case when you look at the intensity of the drug effect after their dose of psilocybin, that the magnitude of the colors, the intensity of the colors, that did not seem to really impact the spiritual significance that they ascribed to this. So again, it may be also a conscious experience, an interpretation of that experience. And that's why we think that the integration following the doses of psilocybin, other psychedelics, is fundamental to the optimal therapy when we use these drugs. You'll also hear questions about microdosing of psychedelics. And quite honestly, you have to ask the person what they mean by microdosing. Is it truly a subperceptible dose? This would probably be about 1 milligram of psilocybin pure, or about a gram of mushrooms. Or is it a little bit more to give you kind of a sparkle, make a few more rainbows in the sky? It's not really clear. And the one study that I'd like to point out that was done by Harriet DeWitt down at the University of Chicago looked at 2 different doses of LSD. This is as the base. You'll see numbers on the graphs that are a little bit different, versus placebo. These oral doses were given every 3 to 4 days for 4 doses. So only about 2-3 weeks of therapy. The reason that they were separating it by 3 to 4 days was to make sure that the serotonin receptors were not downregulated, that they were nice and fresh and polished. There's some concern that daily use would downregulate these receptors, but at low, really subperceptible doses, it's not clear that that is going to happen or be necessary. What was really interesting is that the subjects in the 20 microgram dose group felt that they performed better in their cognitive performances than their baseline. And that was not the case. When you looked at the actual data, neither group of the 10 or the 20 micrograms of LSD base performed better than the placebo. And we see this in various cognitive performance tests, the digital substitution test here, the NBAC number recall did not improve with these microdoses of LSD. Now you could argue, well, maybe you need more than that. It's difficult to do these studies. And yet there's no evidence at this point that microdosing improves cognition. Having said that, Dr. Witt did find that there were some EEG changes. So perhaps something is happening. It may be that we just need to treat for a longer period of time. Having said that, one of the major concerns that we've got with chronic microdosing of psychedelics is that there are other receptors found in the heart that lead to, in mice or mouse models, an increased hypertrophy of the cardiac valves in the chorda, and a valvulopathy develops in these mouse models of chronic dosing of serotonin agonists. So our major concern about chronic dosing of psychedelics, chronic dosing at microdose levels with the psychedelics, is this cardiomyopathy that is undescribed in humans. So we need to do some more human studies for chronic dosing to decide whether or not that is or is not really a problem. All right, now I wanted to say a few words about MDMA, assisted therapy for PTSD. You may know it on the street. Well, others may know it on the street as Molly or ecstasy. And the sponsor of the drug that was presenting it to the FDA has come up with a new generic name that is medomethamphetamine. Sorry, I need to practice it more too. Medomethamphetamine, and it is a neurotransmitter releaser, but it's not so specific for serotonin. It releases or it decreases the reuptake of serotonin, dopamine, and norepinephrine, as well as having some direct discrete receptor agonist effects as well, giving it a very different impression after dosing than the psychedelics. We don't typically consider this to be a psychedelic as much as an entactogen. That is, it provides increased trust and empathy among the person that's taken it and their therapist. Elimination is half-life is longer. We have to keep these individuals around typically overnight. And it has a different toxicity profile, a little bit more worrisome than with psilocybin. And there are some rare cases of hyperthermia, convulsions, and liver damage, but these are reported for the out of the emergency departments where individuals have taken some pill that was handed to them, and we don't really, frankly, know what's in it. But we have not seen these toxicities in the clinical studies in which the synthetic MDMA has been used. The results out of the Lykos phase 3 studies has been very encouraging. Individuals with an average of 14 years of treatment-resistant PTSD were in these studies. They received 2 doses of MDMA, 120 milligrams orally, and then a booster of 80 milligrams at 2 hours. And then they received this 3 times, about a month apart. They also received a rather protocolized psychotherapy with independent assessment. And you can see on the left, the group that received placebo with that therapy, and on the right in the red, that group that received the MDMA-assisted therapy. And what you see in the terms of the individuals in remission, that is with a CAPS-5 score less than 11 and loss of the diagnosis by DSM, a doubling of the remission rate of PTSD. We see also improvements in terms of responders and the loss of diagnosis. But what's really remarkable are those people that have such a dramatic drop in their CAPS score. So Lykos took this to the FDA as a new drug application. And interestingly, despite the fact that they were guided by the FDA in terms of how to write their protocol and how to do their assessments and what kind of other things that the FDA would be looking for, the advisory committee voted in June that there was not sufficient evidence to support the safety and efficacy of MDMA-assisted therapy for PTSD. And they actually declined in the full committee to approve it in August. And if you wanted to read more about why and some of the transcripts, I'd point you to this Psychedelic Alpha blog that Josh Hardman puts out of the UK. Here are some of the concerns that the FDA had, that they were concerned about blinding. How do you blind MDMA when you have this very dramatic effect? It's not psychedelic, but it does have a very calming, anxiolytic, trust-building experience that amplifies the interaction that the subject is having with their therapists. Even more of a problem are the psychedelics like LSD and psilocybin. How do you blind a treatment that a year afterwards in most people is one of the 5 most significant things they've ever done? We're a little bit concerned about the fact that these subjects are vulnerable. They're under the influence of the psychedelics, and especially the MDMA with its trust building. It's used for sexual abuse in some party contexts. There's been fewer than a handful of reports of inappropriate therapist behavior, but it's something that the FDA is very concerned about. But this is something that practice guidelines, I would imagine, should be able to address any kind of therapy. There was some concern about safety data. And one of the things that we've been asked to do going forward is to look at some of the things that we would normally think to be a good thing and report them in the context of an adverse event. For example, if a patient who's depressed, we are now expected to report if they had a positive experience, or that their mood has improved, or they seem to have more energy. All these things in a person who has depression would be a good thing, we think, but the FDA is concerned that these are maybe red flags for the use of the drug, even though as we are giving it, we are handing the capsule to the individual. The risk of diversion and abuse is really non-existent under current protocols. There's some concern about the expectancy effects. A lot of these individuals had MDMA experience, but when they parsed these individuals out, that really didn't affect the data. And then one of the other things that the FDA is grappling with, as are we, is what kind of training and experience do the therapists or the monitors need to have? How should they be trained? How consistently? Who should control that and uh, qualify that training? And should that training be drug or disease specific? Should the treatment of anybody with PTSD have a specific protocol regardless of the drug that they're getting? Or should that be reversed for the drug that's being used regardless of what disease is being treated? I mentioned that therapist or monitor as a component of the protocols that we're using for dosing individuals with psilocybin or MDMA. Again, these are research protocols. We first give them a SCID or a mini psychological exam as well as medical screening. Typically medical, we're looking for individuals that have a risk if their heart rate goes up to above 160 for an extended period of time. And there's some evidence of a QT prolongation with psilocybin, although I've heard through the grapevine that in a more rigorous study was disproven. Then they get 6 to 8 hours of pre-dosing counseling before their initial dose. This is typically broken up and it talks about intention setting, expectations of what's going to be happening, who the people are that you're going to be working with, where the bathroom is, how you tell us that you need to be reassured or go to the bathroom. And then there is an 8-hour dosing session. And this is in a setting. I'll show you a picture of our setting here at the School of Pharmacy. They are attended by 2 monitors, as the FDA calls them. Others would call them guides, therapists, facilitators. The study physician needs to be available. And of course, research coordinators are invaluable for our work. And then we give them eye shades so that they can sort of internalize their experience and have headphones with a preset music playlist. And depending on the study, we'll keep them overnight. Even though the psilocybin psychedelic effects are gone at 8 hours, we will keep individuals with opioid use disorder or methamphetamine use disorder overnight, just to make sure that they are there the next day for the integration, but also to prevent them from interacting with their dealers or the negative influences that might be potentiating their likelihood of recidivism. There's this neuroplasticity that we see over time after each dose. We don't really know how long that lasts, another one of our concerns. And so we want to at least have that 24-hour period that we can kind of protect them. This is a diagram from the MDMA study, the phase 3, that shows you the time course and some of the interactions, the complexity of the interactions that go into these trials. Do they need to be this complex when it is approved by the FDA? It will probably have some of these components in it. You see the taper here for the antidepressants, the preparatory sessions that they're having with their counselors, the 6 to 8 hours. These blue bars are the independent raters, so we can ignore those. The doses are here in the red. You see 3 doses a month apart, and then the 3 integration sessions where we bring them back. A lot of time going into these dosing sessions. Here's our dosing room at the School of Pharmacy. We turn the lights down. You see the 2 chairs here for the monitors, the therapists, and the nice long sofa for the person to lie down. We also can wheel in the folding bed in between here so that they can sleep in this room overnight with a minder in the adjacent room. Now, think of this. We have this room. We're going to bring the person in the day before so that they can be oriented to the room, the people, the facilities. The next day, we bring them in for the entire day to be dosed. And they may stay overnight, they may go home, but they bring them back the next day regardless for the integration or debriefing session. And so what that means is that we're using this room for 3 days, and we can only then dose 2 people per room per week. That's one of our pinch points. Drug is actually not a pinch point. USONA, I understand, is building a plant down at the intersection of PD and Verona Road that can make kilograms of the psilocybin. That's not going to really be a dose limiting factor. It's going to be more the dosing rooms, as I've alluded to, and the clinician availability. As I have alluded to with that diagram, we have a lot of contact with the subject, patient in the future, roughly 6 hours of prep. And again, these are dyad therapist teams. So we have to multiply everything by 2. Got the dosing session. They have to come in a little bit early, leave a little bit later. 2 people doing that. And then the debriefing session where they're coming back in. Total of roughly 40 hours for every session. Well, for every single dose. And then if you add on additional doses, that goes down a little bit per session. But just for the therapist time, we're looking at about $4,000, not counting the cost of the room, not counting the cost of the drug itself and other things. So we're looking at thousands of dollars. Now, is there a way that we can make this attractive to the insurance companies by saying, yes, it's $4,000, but one dose seems to have the same effect as 6 months of an SSRI? That answer is not yet available to us. One of the other problems facing the companies that are trying to develop these drugs is that these are natural products, especially the psilocybin and DMT, difficult to patent, if not impossible. That's why Cybin is looking at deuterating psilocybin with the deuterium. And we don't also know what kind of model these companies are going to require for the use of their drugs. Lykos was trying to tie their therapy and the therapists that they trained to their drug use, and so it was a package. And the question is that really required? Do we have to use a particular company's psychotherapy? FDA does not regulate psychotherapy or practice in general, right? It regulates drugs. And so the question is, what kind of requirements is the FDA going to require of the therapists? It may not be the FDA, it may be more the state, and that's what we expect to be the case. At what point do these drugs become first line as opposed to a salvage therapy? The evidence that we're seeing with the treatment-resistant depression, with the compass pathway studies, is that they're not responding as well as the individuals that are not yet treatment-resistant. And so that may argue for these drugs, such as psilocybin-assisted therapy, to be used sooner rather than later. So one of the learning objectives for this presentation was, what are the requirements that the FDA has for therapists? It's actually a trick question. There are none. There are no FDA expectations for therapists in regards to being appropriate for psychotherapy. There's no training required of the individuals with these credentials to be considered an adequate monitor for psychedelic dose. That's going to be a problem. It's curious that they don't expect any specific psychedelic training for any of these individuals. And then you've got all of these groups that are credentialed at the state level. And are they going to be able to agree upon among themselves what training is necessary to serve as a therapist for an individual that's getting a dose of MDMA for PTSD, or psilocybin for depression or substance use disorder? And then if our state boards can agree, will they agree with the state boards from adjacent states and so on? So this uncertainty about what training, what credentialing requirements are going to be needed or required by the states as psychedelic therapists is, again, one of those uncertainties that we're grappling with. We don't really know really if there's going to be a difference in the training for MDMA versus PTSD. Right now, the MDMA therapy is a much more protocolized template, if you will, for the treatment of PTSD, as opposed to psilocybin, where the therapists or the monitors are more protecting the space, providing reassurance if necessary, but not as actively engaging in psychotherapy during the dosing session. It's more afterwards that they're working with the subject in the integration or debriefing stage. Is the therapy going to be different between those individuals that are getting psilocybin for depression as opposed to substance use disorder? That also has not been defined, although we're using the same therapists for both of these indications. And so at some point, we're going to have to probably tease this out. And one of the reasons we want to do that is, do we need the level of training for these monitors for the psilocybin to make sure that they're kept safe? And can we just use the trained psychotherapists for the preparation and the debriefing, the integration, and just protect them during their experience with lesser trained individuals? I doubt that the underground therapists that have been working for decades dosing individuals with psychedelics will be grandfathered into the state practice guidelines, but we'll see. And then there's also the question of who can prescribe. Can we be more efficient? Can we decrease the costs and increase the access to these psychedelic therapies? Right now, we have one subject monitored by 2 therapists in a room for at least 8 hours. I've talked about some of those pinch points. Can we do something more like what we see with some of these ayahuasca ceremonies in South America, where we've got multiple individuals sipping the brew and a handful of monitors, of guides, of healers, if you will, that are attending them. Can we use drugs such as 5-methoxy-DMT to decrease the chair time? It has a very sudden onset, sudden offset. So the chair time is roughly 2 hours or so. And that's very attractive if you want to treat more people. But it's not clear that that's the best experience for these individuals, the most therapeutic. And that's one of the things that we're going to have to test. For example, 5-methoxy versus psilocybin, 2 hours versus 8. Do you need more time to work with the drug and kind of get used to the experience that you're having and then work with it, as opposed to just kind of defending yourself against the shock and awe from a 5-methoxy-DMT experience? Some people ask if we can dose individuals at home. And that may be a possibility, but it may not be the right possibility. The home environment may have a lot of distractions and noise that prevent the individual from really working with the drug and focusing on the drug's effect. There may be some negative influences, abusive environment, or a negative environment with drug abuse, for example, in the home. So it may not be the environment that these individuals need, but we still need to explore instances, for example, in end-of-life terminal illnesses where we're trying to decrease the existential distress. Maybe this is a good environment for individuals to do this at home. Also, some concerns about the recreational use of psychedelics. Certainly that's out there with mushrooms. I can't tell you the difference between a shiitake and a dried psilocybes mushroom. And so if somebody sprinkled some PCP on, or ketamine, fentanyl on a shiitake, I wouldn't know that it was not the right mushroom. We see in the lower right that there's a wide variability in the psilocybin content of various psilocybin mushroom species. And if you look at the third versus the second bar, you can see that there's a fivefold difference, over fivefold difference in the amount of psilocybin per gram of these mushrooms. So in addition to the risk of adulteration, that may be explaining why on the lower left, people are getting sick from some of these edibles that are available in an increasing number of states and municipalities. It may be the differences in the amount of drug they're taking. It may be some adulteration. And then a really interesting and perhaps concerning, well, definitely concerning report out of Canada, where they looked at 9 million emergency room visits, and they looked at those individuals that came in for issues that arose out of their experience with a hallucinogen, anxiety, dissociation, something like that. Anything that was coded as being related to hallucinogen use in this in these ED visits, followed these individuals, and there was about a threefold increase in the risk of schizophrenia spectrum disorder. So this is a concern. We don't know if these individuals took it again or took other drugs, what happened downstream. But it's one of the reasons why we don't let just anybody take these drugs in our studies, that we do a SCID or a mini and not only do we exclude individuals with schizophrenia, psychosis, bipolar 1, bipolar 2 may be allowed in the future. But we exclude these individuals, and in many cases, first-degree family members with those diagnoses as well. Okay, so I wanted to briefly touch on some of the things that are happening at the UW-Madison, and I want to put up these two slides again to remind myself not to be a Debbie Downer, that both in the context of the MDMA-assisted treatment of PTSD, we're seeing really exciting, promising results. And in the case of psilocybin for depression, we're seeing some dramatic and durable effects after one dose of the drug. Okay, so we have this new Transdisciplinary Center for Research in Psychoactive Substances, and we call it psychoactive instead of psychedelic substances, both, frankly, for a little bit of optics, and also to recognize that it may not be that we need to establish a psychedelic experience for these drugs to have a therapeutic effect. We have a reach across campus that is growing, and we encourage individuals on campus, as well as in the School of Medicine and Public Health, to join us if they've got some interests in working in this area. We, as was mentioned, did a phase 1 study where we dose escalated psilocybin in normal adults, and we also participated in several of the registration trials that I've mentioned already. We have strong expertise in substance use disorders. Here are some of the investigator-initiated studies led by Dr. Randy Brown, Christopher Nicholas. We're looking at psilocybin in individuals with opioid use disorder and with methamphetamine use disorder. The the funding has fallen away from the venture capital group that was funding our methamphetamine study has pulled out. So we're stuck with just 3 out of the 10 subjects that we wanted to look at. But in those 3 subjects that we treated with 2 doses of psilocybin, we've seen a 90% drop in their methamphetamine use, 90. So something really dramatic is happening within a few months of this. Again, it's a combination of the psychotherapy and the drug we feel. Dr. Hutson is looking at an IV preparation of psilocybin that we came up with to compare the experience, the recalled experience, and the high definition EEGs in individuals while they get the drug while awake and asleep. We're having a hard time keeping them asleep, quite honestly. So we've given them some clonidine to try to decrease some of the autonomic response, and that seems to work. Dr. Kalin has an interesting study looking at non-human primates and the effect of ketamine and psilocybin on threat response. And that is going to be really interesting, again, to try to correlate to the human studies of PTSD. Dr. Hutson also has a follow-up study to his recap trial in which we're comparing high and low doses of psilocybin as a control. And then Dr. Leonard's one of the anesthesiologists and his team are giving injections of midazolam during that experience in awake subjects to try to block the memory of their experience. Asking the question, how much of the experience, the psychedelic experience, do you need to remember for it to be salient and have an effect afterwards? So this is a study that's open, looking for 100 normal volunteers. Dr. Hutson also and collaborators. It's a multiple investigator group, of course, looking at the enhancement of vagus nerve stimulation and the cognitive enhancement that we expect to see with the VNS given before or after psilocybin. Is there some sort of a reinforcement that the psilocybin provides? And again, we're accruing about 100 subjects for that study. We have Dr. Ryan Harenga, also from the Department of Psychiatry, looking at intravenous ketamine-assisted therapy for PTSD in older adolescents. This is a really novel study. We're really excited about it. And also it may lead to a subsequent study of MDMA as well. We might be comparing the two. Dr. Heather Barkholtz looking at the differences in delta 9 versus delta 8 THC and the treatment of, their impact on driving performance, since delta 8 THC is legal and widely available. Does it affect driving? Dr. Cody Winther has a really fantastic animal translational program going on, looking at the effects of entourage differences between various psychoactive compounds in his mouse model, but also some interesting diversity issues that are arising. What kind of differences would we expect in the experience depending on the race, the ethnicity, the art, the music that people experience during their session? We also have some sponsored research underway at the EW. Dr. Brown looking at, is the PI, local PI for a study of intranasal 5-methoxy-DMT and the treatment of major depressive disorder. And again, this is the synthesized extract. We're not squeezing or licking frogs for this. And then another really exciting and important study from Dr. Stowe from Department of Psychiatry, looking at 4-hydroxy diisopropyltryptamine for postpartum depression. You have the structure given here. And what's really kind of interesting about this is that even though it's a psychedelic, the DEA has not yet scheduled it as a psychedelic. So it is not technically a Schedule I drug like all the other drugs that we're working with, which is frankly why I think the company is trying to use it. But some really encouraging results in the preclinical work. And so I'm really excited to have that here. Now, there's some opportunities if you wanted to follow this, this literature and this science. I wanted to highlight that Paige Wilson, one of the Ebling librarians, has done a fantastic job of curating a lot of these materials and putting forth a curated list of articles. And this can be found through the pharmacy subject guide at the Ebling Library. And I encourage you to take a look at that if you'd like to learn more. And then also I'll point out again, the Psychedelic Alpha, a very credible blog that talks about the business, the politics, the regulatory, as well as the science issues of psychedelics. I'll conclude by thanking members of my executive committee and the advisory committee here on campus, and also in the lay public. I encourage you to take a look at our website, and I'll thank you again for your attention and invite questions.
Great. Thank you for the overview. I will admit, I must be living under a rock. I have never heard the term "licking the toad," so I'm just oblivious to all of this.
So I have been told.
Yeah. I know there is one question in talking about the neuroplasticity and synaptogenic potential of the drugs. What do you think about potential benefits for treatment of Alzheimer's patients in a cognitive rehabilitation mode?
There's a lot of excitement about that. And again, I think a lot of the emphasis is going to be in individuals who are early stage as opposed to late stage, and in part because late stage might be very distressed by the psychedelic experience that they're having. But the early stage work has been promoted by multiple scientists and also some companies looking at this as whether or not there's going to be some benefit. There's also interest in post-stroke treatment with psychedelics and other neurodegenerative diseases. So there's a lot of early work being done here, and I think that in some cases this is going to be proved to be a very effective, a very helpful intervention. It's difficult to make some of those correlations with the mouse models that at this point are so encouraging.
And you also talked about the use of some of the psychedelics for various substance use disorders, alcohol, smoking, etc. What about the use of this as an adjuvant therapy in weight loss? Yes, you smile.
There is some work in obesity, but most of the interest has been in the areas of other eating disorders, anorexia nervosa, and binge eating. Given that anorexia nervosa is the most lethal of the mental illnesses, as I understand it, that's a very difficult group to treat. But Johns Hopkins and a European group are looking at anorexia nervosa as well. Yeah, I'll leave it at that.
Okay.
Doc, I'm sorry, my camera went off. I'd like to ask one follow-up question. You talked a bit about the FDA's guidance or decision for the MDMA trials for PTSD, and one of the major concerns being dealing with the blinding. I'm curious if they've given guidance. You know, I saw using niacin in some studies, Benadryl, Ritalin in other studies as placebos. Has the FDA given guidance, and is there a growing consensus in the literature about how to address some of these really foundational scientific issues related to, you know, what inferences we can make with some of the challenges with blinding and placebo?
Great question. I think that most of us are anticipating that we're going to be needing to use an active form of the drug, and not perceptible necessarily, but given to everyone either the 25 milligrams of psilocybin, for example, or a 1 milligram dose, everybody is told that yes, you are getting psilocybin. And if we take naive individuals, they're not going to have an experience that will tell them whether or not they are getting the experience that they should expect from a 25.
Yeah.
I think niacin, Benadryl are going to be discouraged in the future.
Interesting. Another question, since you mentioned that the receptors for the psychedelic drugs are present on immune cells, is there anything known about the impact on immunity or host defense during the use of the drugs?
That's a great question, and I don't know the answer to it. I do know that Chuck Nichols' group down at in New Orleans has found that there's a dramatic anti-inflammatory effect in the brain from most of these drugs, some that are psychedelic, others that are not so. And so there's a lot of enthusiasm about some of the anti-inflammatory effects in the CNS. But in terms of immune function, I should know that, and I don't. I'm sorry.
Oh, okay. All right. Well, we are at the hour. Thank you all for your attention. Dr. Hutson, thank you for really mind-expanding grand rounds. And I hope everybody's travels and trips over the holidays are safe. And wish you all a happy holiday season. And we will see you in the new year for our next Grand Round series. So take care, everyone.